with no further ado, let me get started. So hello, everyone. I'm Annette Nabavi, and I'm one of the board directors here at WiTT. We have two other board directors at the moment in the room, and one due to be here any minute. So Audrey Mandela and Yasmin. Oh, she's doing badges. And the other board member who will be coming very soon is Helen Kaliski. Just to give you an idea of who we are. So the event will last about an hour, maybe slightly longer, depending on how well we get on. And there's going to be a little bit of time at the end for you to ask questions. And as Lucy said, there'll then be some further drinks and some canapes. So please stay and come and talk to the panel and talk to each other. That would be great. Just a quick word on my background. Before I introduce the panel of speakers, I'm currently a non-exec director on the board of a couple of AIM-listed companies, one a software company, the other a technology company. So I've got a technology background and have been in technology one way and another for a very long time. So WiTT last looked at this area of health tech, med tech in 2019, and actually an awful lot has changed, developed, moved on since then. And so what we're really going to be looking at this panel, on this panel, is how have things developed, where are the big trends going, and how does that affect all of us, and to some extent what's worked and what hasn't. So and I'd also like to thank Venner Shipley very much for putting us up. That's really, really kind of you. So we've got a great panel tonight. We've got Karen Taylor, head of the Centre for Health Solutions at Deloitte, Dr. Ekanjali Dhillon, who's the Digital Transformation Change Lead, is that correct?
That's correct.
HCA, and she'll tell you about that. Miss Adeola Olaitan, have I got that right? Great. Who's a consultant gynecologist, gynecological oncologist. Why do you have such long titles?
It is. You did very well.
And then Anne O'Neill Way, co-founder and CEO of Adora Health. And you've probably seen their full CVs. I won't read them all out. So I'm going to ask Karen to start the session. She's going to run through the most recent Deloitte life science and healthcare predictions for 2030. And I'm then going to ask Ekanjali to comment on these from her perspective as the digital transformation lead at HCA. So Karen, over to you.
Thank you, and thank you for inviting me. So this is our fourth set of predictions. We've done them every 3 years since 2014, looking 5 years ahead. 5 years ahead because it's not that far away that you can't imagine what it might feel and look like. But looking at, okay, how are we going to get there? What are the things that are going to really make a change to the way that care is delivered, clinical trials are run, the commercial operations of a pharma company operate. And so in doing the predictions, we look at the evidence today to allow us to predict tomorrow. And as you'll hear from some of the innovations here, there is evidence today, but it's not at scale, it's not adopted at scale. So what is it that could help you get that adopted at scale? We also, as I say, imagine what it might feel like if you're an entrepreneur, if you're a chief executive of a pharma company, if you're a chief executive of a hospital or a clinical information officer, and got little vignettes on that. When we did our last predictions in 2020, it was in the middle of COVID, the first year of COVID. And so we looked at how the pandemic was changing the predictions. This time round, we have looked at Gen AI and Gen AI in particular, and how they could accelerate the prediction if they're adopted. But there are also 4 constraints across the predictions that could stop the prediction happening, or could actually, if they could be turned into enablers, could again accelerate the pace at which the prediction is achieved. And those are having the right skills and talent. There's no doubt that digital transformation technology runs throughout all of the predictions. And I think it's very hard to find a solution today that doesn't involve some form of technology intervention. Yes, people are really important, so the skills and talent, but also the skills and talent and the understanding of technology is something that has changed and is changing. Now it's understanding how AI can actually help. yes, keep the human in the loop, but AI is transformative, particularly Gen AI, and it can impact across, as I say, all the predictions. There's the second constraint that we look at it as how it looks when it becomes an enabler is the need for new funding models. You see in the news at the moment how stretched the NHS is. The funding model for the NHS seems pretty broken. What alternatives could there be? But while still keeping the ethos of our health service still there. What are other countries doing? Every country is struggling to have a sustainable healthcare system because of the cost of running healthcare system with aging and more complex populations. So new funding models. The third constraint that can also be an enabler is regulatory change. Often in healthcare and life sciences, the regulators are blamed for not being able to do things. When actually the reality is there's very little that they actually stop you doing unless it's going to be unsafe for patients or there is no evidence whatsoever of improved outcomes. So working with the regulators can really help you get that adoption of the technology or whatever the solution is that you think. And then finally, the constraint is data privacy, and data interoperability and digital transformation, because there's no doubt that what really is the thing that runs throughout all the predictions and everything that we're seeing about the innovations in healthcare and life sciences is access to data that allows you to understand what's happening, and not just patient data or the data that's at your fingertips, but being able to bring lots of different diverse data sets together. So those four constraints can become enablers. And we imagine that they are, because our predictions are deliberately optimistic and hopefully a little bit provocative. And I'm not going to be able to tell you all of them, and I'm not going to tell you very much detail about them, but I am going to hopefully be able to just run through them quickly. Can I have the next slide? Yeah. So I'm going to only talk about the 6 of them that are blacked out. And the first one, which is a really big change that we're seeing, is, but we have talked about it for a number of years, is the consumers, and I know patients don't like to be called consumers, but actually at the end of the day, they are consuming healthcare. Consumers become the CEOs of their own health. They have access to their own data. They decide who to share it with, and they act on the data that they have. But from using wearables, point of care diagnostics, perhaps getting their own genome tested, but that information empowers them to make changes in their own health. And actually, we need that. All healthcare systems need the individuals to take more responsibility for their own health, so that healthcare can intervene only where it's necessary. And we have a healthier population because people are making much more healthy decisions. Now, of course, that's rather a nirvana, because there will always be groups of the population who have already got large complex illnesses, but even they can be supported through the system, through technology, to be able to make better decisions about their health and actually have the potential to recover more effectively. Alongside consumers being the CEO of their own health is the actual rise of a very innovative and dynamic consumer health industry. And we've seen a number of the big pharma companies spin off their consumer health arms, recognizing that there is huge potential in the consumer health market. And so you've got GSK, who spun off Haleon, which is a massive company in its own right, Kenvue from J&J, Apello from Sanofi, and there are many other of the large pharma companies looking at divesting themselves of their consumer health arm, acknowledging that the constraints they work on in developing drugs are not necessarily the best environment for consumer health products. So there are many, many consumer health products out there. So one of the elements within the prediction is the need for companies to have evidence-based of outcomes, to be able to demonstrate to consumers why this product will help them and how it will help them, and to support them in using products, using technology through virtual bots, through Gen AI enabled coaches, avatars, to help people understand how they can really improve. And the consumer industry is investing in these to help the consumers ultimately to buy their products, but nevertheless to improve. And one of the big benefits we envisage is improvements in individuals' health literacy, because that is a constraint to being able to take advantage of all the innovation we're seeing. The next one I'll talk about is intelligent healthcare and the democratization of health data. And that's really looking at the healthcare system that we have today, where largely most of the activity takes place in our, or most of the cost goes to our acute hospitals, which people seek support from when in a reactive manner when they have got to a point where their health is deteriorating. And what we're envisaging here is, because of all that data, and because there is actually an awareness amongst policymakers of the need to intervene much earlier, to get earlier diagnosis, to provide care where people are in the communities. And our own health secretary has got the 3 shifts that he's going to include in the new NHS plan. But they are things we've talked about for a long time. But we also see that having that data and having the interoperability between the technology infrastructure allows you to make these decisions and to provide digital first access. It was one of the benefits we saw through COVID, people actually starting to use digital access into the healthcare system. But all of that data is allowing you to make decisions and allowing the healthcare system to operate much more efficiently and effectively. So also reducing the cost of running it, reducing waste, being able to have more efficient use of the clinical staff who've been trained very well and who want to practice at the top of their license, but often find themselves handling paper records, searching for paper records, or having to manually input people's vital signs. That can all be improved through technology, and we see that happening. And we think the time is now. We've talked about it for years, but the time is now, and the infrastructure is now there, and the technology is available. I'm jumping the next 2, and I'm going to health innovations and science and technology. So again, this prediction is about the science, and our knowledge of science has increased exponentially. We know so much more about health, about science, about how the body works, about the challenges they face. There's still a lot more to learn, but we have got much more understanding. We know much more about cancers, for example, and I'm sure you can come back on that one. But knowing that and being able to have much more precise diagnosis and then precise treatments will make a big difference to patients' outcomes. But as those innovations in science are happening, so too is technological innovation. And the two are feeding off each other, so that we've reached this point where we think that there is this pivotal point where that technology will actually help the science, and the science will help the technology improve outcomes for patients. MedTech innovation. I don't think there is really many at all consultations between the health service and the patient that does not involve medtech. Whether it's just a stethoscope, we still use the stethoscopes around the doctor's note, even though there are really good digital stethoscopes, or it's blood pressure taking. Again, they still have the old-fashioned blood pressures in most GPs' offices, when you can actually take your blood pressure much more accurately and easily through technology. But medical technology touches all of it and is integrated, and what we're envisaging in the prediction by 2030 will be integrated into all patient pathways, and be able to not only do what it's intended to do in itself, but also to collect the patient's data that shows how they're responding to whatever the treatment they might be on, or to whatever activity they're undertaking. So, and together, the medtech and the consumer and the intelligent healthcare together form, help us achieve the ambition of 5P healthcare that is more preventative, participatory, proactive, and I always forget the 5 Ps. Participatory, really important for the consumer, but prevention, participation are really important. Precise, that's the other one. And then finally, I'm going to talk about health, wealth and longevity, where services converge. And this is back down to that, who's paying for your healthcare? What the COVID pandemic did demonstrate very clearly is that the importance of the health of your employees If you've not got healthy employees, you can't have a productive workforce. And if you haven't got a productive workforce, we're not going to have a healthy and wealthy economy. And that has become a much more topical subject over the last few years. And in this prediction, we're envisaging collaborations and partnerships between employers, between insurance companies, between funders like PE companies and venture capitalists, as well as government, all at the table to work out how best to deliver optimal healthcare and improve the health of their population so that we have a wealthy economy. And I think I will leave it there.
You've done very well.
And I
Thank you
don't
very
know how long I
much.
took because I completely
No.
lost time.
Perfect. Absolutely no problem at all. And all sounds like nirvana. As far as I'm
And I said,
concerned.
deliberately optimistic. If we can only get halfway there, it'll be better than where we are now.
It's absolutely true. So, Ekanjali, I just wanted you now to give us a little bit of a feel for how that all plays out in the world that you're in. You're looking both forward and also at the present day. So give us a little bit of a comment on some of those predictions, please.
Oh, sure. And good evening, everyone. I'm Ekanjali. I'm actually a physician by background, and I transitioned into and found myself in this wonderful world of health tech at the moment. So that gives me a bit of a unique lens when Karen and her team and the bright minds there give us these predictions, and we look at them as an organization and think, okay, what does this mean for healthcare? How do we reimagine the landscape? And what does that look like a year from now, 5 years from now, and 10 years from now? So when you put it all together, standing back, I think we're looking at a totally different healthcare model. And we're looking at patients expecting something different from the way they interact with their clinicians. If you think about banking, right? And they're a great example of practices that were very different 5 years ago. You used to stand in a line and wait and speak to somebody at Barclays, and that's what you thought banking was. Well, that's been completely changed over the course of the last half decade. And I suspect with some of these predictions, we'll be looking at a healthcare model where you can access it and your information and your data as easily as checking your bank account and banking that way. And that would be my hope, because what does that ultimately mean for us, even as patients? All of us in this room are also going to be patients if we haven't been already. And yeah, that I think presents a whole different world. So a couple of the predictions that I wanted to go into, and I don't know if we could go back to that slide, but the CEO of, or the consumer as the CEO of their care. I think with the trend that we're seeing in wearables, and I don't know if anybody in the room has tried Zoe or, yes, I'm seeing a few nods. So continuous blood glucose monitoring, that's been commercialized. So people are far more aware and potentially preventing type 2 diabetes and other conditions, and being able to manage things like obesity in a completely different way than was being done even a couple of years ago. Right. And I think that trajectory is looking really different. So us as an organization in HCA, we're putting a lot of effort into what does ahead look like. Now that comes with some challenges. You have to take stock of your infrastructure where you are right now. So for us, that means becoming fully digital first. So it's great to think about medtech innovation, but we really can't get there until we're all digital, and that data and the interoperability that you spoke about is there. And I think if you've been in the NHS or a big organization like HCA and access care there, sometimes I find patients always asking me the same question, which is, don't you have that information already? Don't you have that information already? Or you keep asking me my allergies, don't you have that information already? And I have to break the bad news of, sorry, that information doesn't travel, even if you're within the same organization. And why are we still there? So the near future looks like, actually, how do we improve the landscape, the infrastructure, so that we can welcome some of these innovations that are very clearly on the horizon and we want to be part of. So that was one I wanted to hone in on. And in the interest of time, I won't again go into all of them. But the other one, given that this is a Women in Telecoms and Technology event, I really want to raise the gender gap in medicine, right? So for women and research in medical problem. So say dementia is a disease that disproportionately affects women, PCOS, other medical conditions that get brushed aside. And really technology completely disrupts that because it changes the way we can access research, the way we can conduct research, and really the conclusions that we draw at the end of that, which allow us to transform the way we're delivering care to those patients. And then when we look at AI and radiology and the early diagnostics that's offering, that's personally very exciting to HCA. In HCA US, we have rolled out a piece of software where Azra AI is actually the piece of software which hopefully will be coming to the UK soon, which is an AI enhanced radiology and pathology software, which will has over 90% sensitivity in terms of picking up early cancer. And for anybody who's ever cared for anybody with late stage cancer or seen that, it's absolutely shocking and it rips families apart. And the fact that we can look ahead to a healthcare model that completely changes that, personally really gets me out of bed in the morning, and it turns the hair on the back of my neck in terms of, wow, we can really change the way we deliver care for those patients. Now, are we going to change everything for everyone? Is tech going to be for everyone? I would argue no. So having worked in elderly care and care of the elderly, and I sit on the board of Age UK, Harrow, Hillingdon and Brent as well. And there is a risk that we think, technology solves it all, you know, nobody's ever going to fall over ever again because some machine will pick it up and say, give you a beeper. It's not going to solve everything for everyone. And we need to remember that care is fundamentally a human thing, and it is provided by humans. So we're not trying to change that. We're certainly not trying to disrupt that. We're trying to reassign the available resources to target the right patients. So yeah, how much time do I have?
Well,
because I can keep going.
I'm going to ask you and Karen a question, actually, so that so I get a look in as well.
Yeah.
And the question is really about what's been going on today in Parliament. The UK clearly has a big problem with lots of people who are claiming disability benefit and who are therefore unable to work. And they need to sort this out. They need to get people back into work. How much of the technology we're talking about can help us today to do that? How quickly could that sort of technology actually improve the amount of welfare benefit, so reduce the amount of welfare benefit that we're paying out, and therefore improve people's ability to work?
So I'll start. We take it back down to the patient, and I've seen these patients in clinic, right? Mm-hmm. It's taking them a week to get a GP appointment. Mm-hmm. And then they don't know when they're going to get their next GP appointment. Yep. So it's like, oh, well, sign me off for 2 weeks because I don't know when I'll next see you. So
it's a good start, isn't it?
Right. So it's actually fundamentally a workflow challenge. So where tech allows you to potentially see your GP the same day and gives you the security that you can go back to that clinician quickly, accessibly. Nobody, I would argue, and perhaps I'm an optimist like you, nobody wants to be sitting at home forever. People fundamentally or intuitively want to be useful. So if you give them the tools to be able to access that and then inspire that, and perhaps it's not just a healthcare challenge, it's also collectively a societal challenge as well. But where healthcare plays a part is accessibility to healthcare. And I think that's where we're not doing enough. And that's where we're falling behind in this country, perhaps, because it shouldn't take you 2 weeks or a week to access your GP. And that must lead to so many downstream impacts. So that's probably where I would start.
But what about, just very briefly on that, what about the idea that you don't actually need to see your GP first, that becomes a secondary visit, if you like, that actually you're doing some of your own diagnostics? Maybe people don't like you doing your own diagnostics, but lots of people try these days, or at least your own monitoring of what's going on, so that you can do some self-help. Karen, now you talked a lot about some of that.
So, I mean, I think a lot of the problem we face in this country is not people who can't see a GP and therefore are 2 weeks off work, but people who are on long-term sickness disability benefits and all of those things, because they've either not had the right diagnosis or they're not getting the right interventions to help them improve their health outcomes, or their employers are not providing them with flexibility or technology and tools to help them do a job that may be different to the one that they can no longer do because of their health. So I'd say pulling all those together, that, you know, innovations in science and technology, pulling that together, there is a lot more that can be done to help chronic illness, long-term conditions, disabilities. But we also have to change our mindset. The employers need to change their mindsets and be prepared to be flexible and to work different, allow people to work differently, but also provide them with the tools to enable them to work differently. So that's what I would say is why.
Very interesting. We'll come back to both of those. It sounds to me as if whilst we can talk technology up, actually there's a lot of other things that need to be done. But I wanted to move on to Adeola. And Adeola, I thought before we get you to talk, shall we show the little video to give some people an idea of some of the exciting robotic stuff that you get involved with? Is that okay?
Beautiful.
Fantastic. We kept the surgical bits to the minimum on that one. We did have a much more in-depth, in all ways, video that Adeola's got, which if you ever want to see it, just ask her. But over to you, Adeola. Tell us a little bit about what it's actually like doing robotic surgery and what it's like at the coalface.
So what I'd like to do perhaps is pick up on some of Karen's optimism, because I've seen this.
Yeah.
So when I first started training, the only way you could do an operation for a gynecological malignancy was from a stern-to-stern incision in a woman's belly. And she would often be in hospital for 14 days. A lot of people who have cancer have other comorbidities, so they could get wound infections. And then most cancers are multimodality treatment. So you don't just need surgery, you need chemotherapy, radiotherapy. So if you suffer from complications from your surgery, it can delay your other treatment. And then things started to evolve, and none of this is new, by the way. So if we went first for laparoscopic surgery, which is minimal access surgery, where you're actually standing by the patient. And just because history is a side interest of mine, I tell you, the first laparoscopic surgery was actually performed in 1902.
Good Lord.
It was on a dog.
Okay, on a dog.
but you know, the technology has been around for a very long time, but better optics, better power instruments have made it possible to then go from laparoscopic surgery to robotic surgery. And the difference between laparoscopic and robotic is that the surgeon is in the room, but you're at a console and you're moving instruments, which and the movements are transmitted to the instruments that are in the patient. And so they're much more precise. There's less tissue damage and there's actually less visceral pain. So if a woman has a robotic hysterectomy, she can go home the same day, as opposed to 7 days in hospital, that used to be the case. They have 5 little incisions, each is less than a centimetre.
Good Lord.
Held together with glue, so there are no stitches. The glue is waterproof, so you can shower and just get back to normal as quickly as possible.
That's amazing.
And so this has changed things for the patient. It's also changed things for the surgeon, because laparoscopic surgery, which I enjoyed and did for about 20
Can I
years.
just ask, can you hear it back? It's fine. Okay, that's good.
It does involve you standing by the patient. And one of the risk factors for endometrial cancer, womb cancer, is obesity. And if you're operating on a very large patient and you don't have a long arm span like me, and, you know, 6 hours later, I can barely move my shoulder and my thumb's got a neuropraxia. And also all surgical instruments, and there's been a lot of this in media recently, designed for men. They're all very large, and if you have small hands, it hurts. But with the robot, you sit at a console, you make it comfortable for yourself, so you can move the instrument so that you can sit upright, you're not crouching, and everything. It's a bit like, you know, a good car. You can you can design it around you, and also the instruments are malleable and very easy to, you know, if you haven't got very large hands, to work with. The vision, it's three-dimensional. rather than two-dimensional. The limitation of laparoscopic surgery is it was two-dimensional and therefore quite difficult to teach people who don't have that imagination to convert 2D to 3D. Here you're looking in real time. So if you tie a knot at the robot, the robot is, you know, tying a knot in the patient. And it's been transformative. Patients like it. I had a 90-year-old woman who, because the system we use is called Da Vinci. Yes. And I went to see her in the morning and she had a picture of Leonardo da Vinci by her bed. So they, you know, the sort of double intense work. But I mean, this is the difference that it's made. And this has happened slowly and then suddenly it accelerated very quickly, and it's still accelerating. And, you know, we've moved from multiple incisions to single port incision where all the instruments going through the belly button, so you don't have multiple scars. One of the limitations of the robot is that there's no haptic feedback because you're not actually touching the patient. If the instrument touches something, you know, you have to keep all the instruments in view all the time. If it moves out of view, it could do a lot of damage. But now the new models are developing where there's haptic feedback, so you can feel that something's not right. So, you know, things are moving on. It's getting safer. It's very, very safe, actually. And also very few complications. So most people go home the same day, and this feeds to people being economically productive. Because if you can have your surgery and go home the same day and be back at work, and people are working from home very often the next day after they've had an operation. So that's
So you do this mostly now through private practice. So how much penetration is there in the NHS? We obviously saw some robots there. I think you told me that those were not the most up-to-date robots, but they're still robots. Yeah. So how quickly do you think these are being developed into the wider health system as opposed to just the private system?
So there's been a lot of penetration, and actually COVID was an enabler.
Right.
Because people, because of fear of infection, people didn't want to be standing at the patient's side. So you have a closed system where the surgeon is remote and everything can still be done safely. So a lot of trusts, I think there are about 150 robots in NHS trusts at the moment. So a lot of trusts that hadn't previously invested in the robots. And I did my robotic training at UCH, where I was a clinician. And at UCH we have three robots, and I think there's a plan now to buy 2 more. So it's becoming pretty much standard. And I think that I can't think that there are any major health trusts in London that don't have at least one robot.
And the business case sounds very convincing in the sense that, okay, you've got a big capital outlay for the robot itself, but given the amount of money you're saving by not having patients staying in hospital, the turnover that you can get on the equipment and so on, it sounds to me as if it's a business case that you could make without too much problem. Is that how people are making that business case?
Yes. We were slightly, when we made the business case for the robot, we were slightly inconvenienced because we were already such good laparoscopic surgeons, and our patients were staying in for 24 hours.
Oh, right.
So one of my motivations, I said, I promise you they'll go home the same day. That was difficult because of people's mindsets. And even now, however much counselling you give to people about, you know, you're having robotic surgery, you'll be able to go home and get back to work. But my friend told me she couldn't lift a kettle for 6 weeks. And then they come back and see me and they say, I've been really good. I've done very little.
Oh. No, you've got to get back to work.
Get back to work. So it's you know,
so there's no excuse.
Yeah.
Well, that's it. I mean, it's really good to hear that it is so effective. Tell me, can you do robotic surgery at distance? So with robots in other hospitals where perhaps they don't have your expertise in terms of the actual use of them, but you can do it from your console?
The answer is theoretically yes. And actually, again, this isn't new, because people started thinking about remote surgery when they started sending men to the moon in the 70s, and NASA worked very hard on this.
Oh, right, yes.
I think it was 2001 where surgeons in Canada operated on a patient in France. They took his gallbladder out. And more recently, patients in China operated on a patient in Europe.
Wow.
So the technology is here, and despite the huge delays, distances, the delays were milliseconds
Oh, right.
transmission.
So not too bad.
But the trouble that we have is sorting out all the other things around it, like the ethics. And people are very worried about things like surgical tourism. So you want to have bariatric surgery in this country, you can't afford it. Can a surgeon in Turkey do this remotely for you? And if things go wrong, where does liability lie? So the technology is here, but the law hasn't caught up and the ethics haven't caught up. So we are not in a position, this is not mass, available to the mass market yet.
It's really interesting. Well, we've got several lawyers in the room, so you can be thinking about that while we're talking. The robotic surgery sounds amazing, but what is it actually like with all these other things that we've been talking about in terms of being at the coalface as a doctor? I mean, your day-to-day job. I mean, okay, in the when you're doing the surgery, you've got fantastic equipment, all the rest of it, but much of the day job is nothing to do with the surgery piece. You get around to doing that eventually, but there's an awful lot that goes on before you get there.
Oh, totally. I mean, I work in cancer, and so diagnostics are very important to me. And actually more important, if we go a step back, prevention. I think prevention is so much better than cure. And I'm heavily invested in trying to prevent cancers. And I think, again, that goes back to what you were saying about health education, because a lot of people are still completely unaware of risk factors. If I ask what do cigarettes, what are the risks of cigarettes? Everybody knows that cigarettes cause lung cancer. Very few people know that cigarettes increase the risk of cervical cancer.
Right.
That knowledge is not out there. People know that obesity causes heart disease. Very often, the first time that a woman knows that obesity is her risk factor for lung cancer is when she's sitting in my room with a diagnosis of lung cancer. So I think public education is at the key of it, and making people understand what the risks are so that they can make choices about their own health. And if they choose to ignore the risks and continue to smoke, at least they know. I think the pit is when people just don't know that they're putting themselves at risk from their behaviours. So that's difficult. But so prevention is really important. People recognizing that you can be vaccinated against cancer, the HPV vaccine. Screening reduces the risk of cervical cancer, freely available in the NHS. Health management, diet, exercise. But on the other, if you're sitting in my room, say you're either seeing me because there is a suspicion that you have cancer or you have a diagnosis. What I want to deliver is rapid diagnosis. We have very good machines now that do cross-sectional imaging to a very, very high extent, and then plan their management. So we don't work alone, we work in what's called multidisciplinary teams, because as I alluded to earlier, it's very rare that people have one modality of treatment. So you might have surgery, chemotherapy, and radiotherapy. Well, we don't do the operation and then think, what next? Before I even touch the patient, we have a discussion about what's best, and we plan that patient's pathway so she can move seamlessly from one to another. Because I think the biggest thing, if you think you have cancer or you're being a bit, is the not knowing. And I think if you know what's going to happen and there is a pathway in front of you, and also you know who's going to treat you through your whole pathway, rather than somebody finishes and then moves you on to somebody else, I think that's very disruptive for patients. So as much as possible, that's what we try and do.
And downsides of technology or lack of it, where you might find that in your day job?
I think, again, I no longer work in the NHS, but I think that one of the biggest things in the NHS was what you alluded to, lack of transfer of data.
Yes.
So a patient who's been seen at the Royal Free in Hampstead comes to see me at UCH a few miles away, and I don't have access to any, so you have to start again. And it's very time wasting and frustrating for the patient. She's like, I told that story yesterday. So that's very, that's difficult. But I mean, at UCH, we had done what you're doing now. We had digitally transformed and we had electronic patient records. And that made such a difference.
Yes.
Because there's no notes lost on the morning of surgery, or you can't start the operation because nobody can find. So all of these things have been sorted out. So things are better. I can't think of I can't think of any downsides of
Oh,
technology.
It's
I
interesting.
think it's helped us and continues to help us.
Continues to help, but still requires, I think, quite a lot of implementation, particularly within the larger organisation of the NHS, a large hospital trust. And I've certainly seen instances where a failure in technology or a lack of technology, like as you say, notes not being available, a cracked screen that can't be replaced for 6 months, so you can't actually read any emails. I know of one doctor where that happened, and so on. That's where you start to think, well, you know, we're not getting anywhere really. It's all very well talking about these fantastic things, but frankly, we can't even manage to send an email.
The basics,
But that's the basics, exactly. But from what you're telling us, there's actually a lot of hope, which is great. I'd now like to turn, because we are obviously moving on, and I want to give a little bit of time to our audience, to Anne. Now, Anne is the co-founder and CEO of Adora Health, and I think she's got 1 or 2 slides that she'd like to show us. So I'm going to leave it straight over to you, and we may or may not get around to questions. Let's see what you've got to say.
Yeah, I just wanted to give everybody a bit of context as to what we do and some of the choices we made in terms of how to help women manage the menopause, which some of you will go through or maybe have gone through. And those of you who won't go through it, you'll certainly know somebody who does, your mums, your aunties, your sisters, your daughters. But despite that, and going to your point about health education, when it hit me, I had no idea what was happening. I had 5 GP appointments across 2 years, multiple sets of hospital visits, impacted on my earnings, impacted on my confidence to pitch for work. I sort of got to the end of that and thought, I can't believe nobody told me about this. I can't believe I knew about this. I'm quite, well, not that smart, but you know, I'm smart enough. I should have understood that what was going to happen to all women at the age of sort of mid-40s. I should have known more. And it led me to coming up with Adora, which sort of pulls on a lot of the things that have been talked about. It's personalised. It's helping women take control. It's preventative. It's helping women age well. It's helping them understand, but in an engaging way. So they're actually not being lectured or prescribed to in a way that they want to take control and be CEO. I might nick that line.
You're welcome to it. I have patented it.
But to my point, every woman will go through menopause. 80% will have symptoms, 25% severe. For those women, they need specialist care. So they may need gynecology, they may need definitely secondary care. And 50% of women will experience emotional symptoms, and often for the first time, they won't recognise themselves within that. One of the issues in primary care is 52% of GPs just aren't trained enough to help women through something that will last a third of their lives, has 40 symptoms. And a lot of the symptoms are presented in isolation, so they're just not picked up. Next. So what's going on in secondary care? Well, a lot of GPs are referring women to secondary care, waiting lists at 8 months, 630,000 odd women are sitting on those. And when they're on those waiting lists, for 65% of them, their daily lives are affected. And 65% of women actually don't go to work when they're sitting on a gynecology waiting list. Now, our clinical director believes gynecology should be within primary care, but it isn't at the moment. It is a public sector crisis. It is a private sector crisis. One of the most shocking things is the impact it has on a woman's career. Pension pay gap. 1 in 10 women leave the workplace, and then a further 28% of women look to reduce roles or step back. Absenteeism costs from menstrual health costs the UK £11 billion, which was a report that came out from the NHS Confederation last year. So 65,000 women are unemployed as a result of menopause. So there's a lot that could be done to get women back to work. And in terms of how do we care for this when it's something that lasts for such a long time? Well, the point is 1 GP appointment, which potentially lasts 9 minutes, or a telehealth call, isn't going to give information to a woman about symptoms that may unfold and the hormones that fluctuate during this time when they're most symptomatic, which is perimenopause, which is actually a period of years before a woman hits menopause. And then postmenopausally, women experience different symptoms around genitourinary symptoms, so 1 in 3 women will experience those. But of course, none of us are educated on any of that. We don't know about the risks of osteoporosis, so 1 in 3 women will fracture. We don't understand cardiovascular risk. All of these things we should know about when we're 40, and we should be aging, and we should be adopting lifestyle behaviours that help us and improve our health span. And that's really what we've tried to create with Adora, which is it's a health tech platform. It uses conversational AI. And the reason that we chose that tech was because a lot of women go through this and they feel very isolated. It's quite an anthropological angle to menopause. It's women aging. There's not a lot of visibility of older women. It's been quite, there's been a lot of banter around the symptoms. And so there's a need to really empathise and validate the things that women are feeling. And we thought that conversational or empathetic AI was a really good marriage of tech and problem. And also it's a thing that, as you saw, menopause lasts for a long time, perimenopause lasts for 47 years. Women can come in and out of Adora, we'll remember her, we'll understand her symptoms, and we can give personalised, maybe go to your 5 Ps, personalised, precise care.
Predictive.
I'm going to end up just stealing your presentation. That's so predictive.
I'll send you one with more details.
Okay, thank you. Yeah. So Adora is a sort of a personalised menopause companion for women as they go through the stage of life. And it is about clinical interventions. So we have gynecology online, but it's also about nurse chat, because actually women are really busy. They're juggling multiple priorities. They haven't got time to ask about HRT adherence or progesterone or Mirena coil for their flooding. So we have women who just text our nurse, and the nurses are sitting in primary care with 20 years experience and being underutilised. So they're able to get women the sort of care, the instant answers, that the much better than Dr. Google that they need. We work with a lot of partners because trust is really important. We're a class 1 medical device. We work with the NHS. We're funded by the Scottish Government. We're doing workforce public sector trials. We're doing primary care trials. I'm on the board of the UCL programme, which is creating educational programmes for women around the UK. So we're pretty busy for quite a young company. But women are at the heart of everything we do. So we started with their pain points, and we've designed this with 200 odd women. We've also designed with clinicians, primary and secondary care. And so from a data perspective, very secure. And from a clinical perspective, we made the decision to be a class 1 medical device because we just felt it was very important in healthcare. So, and that's me yesterday. I was pleased to say that Adora won is London Tech Week. And we that's Tom Hallis and Peter Kyle. So we managed to say we need help. We need help with many things as sort of female founders, but as a sort of a tool that has a lot of benefit for public sector NHS, for women, and to try and sort out some of this crisis that we see.
So tell us a bit about the AI side of things, not from a technology point of view, but how the AI takes any information that you or a patient, a subscriber is adding to a database of information that you've already got, which I assume is sort of walled garden. So this is not spilling out all over the internet so that everybody out there can gather your symptoms. Tell us a little bit about that and how it works, and how you're gathering data and how you protect it.
Yeah, so it all sort of starts with a clinical assessment, diagnosis, if you like, on a woman's symptoms and how they're presenting and how they're impacting her. And that's the starting point of our data collection. Data is really important to us because there isn't any data, or there's no longitudinal data on menopause, or there's very little. So we don't really know what's happening at this stage of life. So it is really important for us to collect data, and then we use that data to personalise and to prioritise the things that we think women should tackle first. And we also use it to validate the experience. So and that's across all women, because women are really nervous. And is this normal? Am I going mad? Is a question we're asked a lot, because a lot of them get brain fog because of the emotional symptoms of menopause. They don't quite understand why previously they've been quite robust, and now suddenly they're absolutely not, and they're crying when they're driving down the motorway or withdrawing from social environments. So that data is really important for us to help them. And by helping them, they trust us, they come back. So as I say, it might be around HRT. So they might be worried about HRT, which is a really effective intervention for their symptoms. So we'll take them through a risk assessment based on their medical history, based on their family risk. So we're collecting more data there. And of course it's all hosted and it's not, we don't share it, just used to improve the product and to personalize the conversation with women.
So as that data set gets richer,
Yeah,
the application itself will presumably become even more effective
yes,
for people.
yeah.
But will that eventually be shared in any way with any other apps or any other clinical trials or research that's going on, or is it just going to be contained within Adora?
I mean, we want to transform what the world knows about menopause, so that would suggest we would work with the right partners at the right time when our data is useful. So we know we have a private sector go-to-market strategy, but we're also working with the public sector because there's a lot of data that we won't have if we don't make Adora free or available for all women. We don't want to leave anyone behind. So we do a lot of work to understand the barriers that those who are hardest to reach, why they're not accessing healthcare. And there are all sorts of reasons for that. And that's really important to us. And that data will become richer over time.
And how do you deal with the user interface? Because not everybody wants to sit there typing questions into a machine. Sometimes people want to pick the phone up and talk to somebody.
Yeah.
As a more friendly way of dealing with things. Does the app allow you to do that?
Yeah.
And how does that work through with the AI?
Yeah, so you can, you're right. I mean, we have a lot of content. We have audio, we have visual, we have the ability to text, we have the ability for women to ask questions and to get answers from Adora, our relational agent that we're training, have been training for years. And then there's also the phone call to the gynecologist or online if they want either a women's health specialist or a gynecologist. And that is delivered by a service that also delivers to the NHS and is run by our clinical director. So we're trying to be a digital human hybrid tool. So at the right moment, the woman is getting the right thing. We're trying to unburden GP. So my example, 5 GP appointments.
Still, they didn't know what was going on.
I mean, you know, it was astonishing, and it's so not unusual.
Yes,
it's
right.
really the case that so many women have multiple GP appointments. And in Kent and Medway, where we're piloting with primary care, the GPs have called it transformative because the patients are going in and they are educated and they have a checklist, and we create a GP report. And the GP trusts us because they know us by now, and we've been in there, we've worked with them for a long time. And that appointment's a shared decision-making appointment, as opposed to sort of a 5-minute appointment where the woman tries to recall everything and probably quite emotional because it's the first time she might have had a conversation.
And nervous because you're nervous because it's a professional in front of you.
And it's even worse for the really taboo symptoms of women's health. So the genitourinary, the UTIs, the vaginal dryness, the incontinence, all those things that women will self-diagnose or get to crisis before they seek care. So we're trying to advocate and get women to a point where if they have the help that they need. And also in the workplace, because we want to arrest that exodus of brain talent. So the same thing happens in the workplace. Women can't speak up and request an adjustment that would just help them for this temporary moment in time to stay in the workplace, maybe have flexibility around a flooding issue. 40% of women get flooding, no one ever talks about it. So we're really, really digging into their pain points to try and come up with tools that will help them and help them stay in their careers and help them improve their health span and adopt healthy behaviours. And they want to, as soon as they find out their risks, they want to make changes. They're happy to. That's what we're finding.
So who pays for this? Is it an employer at the moment who's actually paying for the subscription?
Yes. So our go-to-market was with the employers and employee benefit. We think employees have a good role to play in public health, and we're the kind of Generation X, we're the first generation of women to go through this in large numbers, about 4.5 million women in menopause in the workplace, and it's of course not set up for us. So there's a little bit of an education and a socialization of the benefits. That's okay, we're doing that. And then the employer buys a subscription, and some of them buy calls to the gynecologists, and then women can pay, but it's a very reasonable price. because we didn't want, there's a lot of women that need the help and can't really.
Yes, if you were inviting individual women to buy the app to put on their mobile phones, you'd only get a certain strata of women who would do that.
Exactly.
It certainly wouldn't bring in everybody.
But the goal
if you try and get the NHS to do it, then you'll be here when we do the next predictions in 5 years' time.
Well, we're hopeful. I mean, we actually started with, because we come, so myself and my CTO, I'm from TV and radio background, he's an engineer, and so we don't have any NHS experience at all in the team. So we went, well, we'll build this great prototype and then we'll go into the head of procurement in the NHS.
Exactly. Head of innovation. Yes.
Yeah. So we had this, we found someone who would take a call, and they said, go away, go away, get the evidence and the traction, and come back. And that was about 4.5 years ago. And since then, we're funded by HealthTech, we've got primary care, we're class 1 medical device, we've gone through the cybersecurity and all of those things. So we haven't given up on it. There's
the person that you spoke to has now been made redundant, and
possibly
their job's gone.
Yeah,
so
Yes, but 80% of the workforce in the NHS are women.
Yeah,
that's true.
The majority of them are in the age bracket where they
this
are going
makes a
to be.
difference.
Exactly. So
So actually selling it
need
to
to
the
make them
NHS as opposed to through the NHS.
well, and it will be richer as a tool as a result, because there is a public-private sector crisis here. You've got private sector workforce exodus. You've got public sector workers who are delivering the public sector services who are not thriving because they're not getting the support they need. Then you've got primary care who need unburdening and support. So that your point about that everyone around the table, it's the only way we're going to solve it, in my opinion.
Now, looking at the time, what I'd like to do is to give a few minutes to the audience to ask some questions. Sarah, your hand went straight up. So off you go.
So I'm tech utopian, really. So I'm sorry for asking such a cynical question. But I remember as an undergraduate student, it's almost 40 years ago, writing an essay on the need for preventative healthcare. So my professor went through, and every time I said preventative, he changed it to preventive. I'm sure I wasn't the first, but 40 years ago, 40 years have lapsed, and we're nowhere near. And my encounters with the NHS and health system and other large institutions, it's not exclusive to the NHS, is that they've got all this data, but they're so overwhelmed with it because they can't see the signal for the noise. So I think opportunities for early diagnosis are missed because nobody's reading through all the data. Communications are terrible. They've got all these different platforms. They will communicate. There's no consistency and nothing patient-centered about it. Just none of the basics are right. So how can these brilliant technical innovations kind of thrive?
So I would say
for the Zoom, Annette, could you please repeat or consolidate Sarah's question?
Sorry.
Yes.
Because
That's a good point. Right. So Sarah has just asked, given that she's wrote an essay on preventative medicine or preventive medicine 40 years ago, and still sees an awful lot of problems with basic data and non-joined up systems in not just the NHS, but other large organizations as well. How can these technology innovations ever get through?
So I'd say two things. Florence Nightingale was all about prevention. So it's a long time that we've known that it's better to prevent is better than cure. You said that, didn't you? And it is a really difficult, because if you prevent something, it doesn't happen. And so the impact isn't as known. And I remember having an argument with some consultants. I did a report, I used to work for the National Audit Office, on hospital-acquired infections. And I was talking to a lot of infection control doctors who were in charge of hospital-acquired infection at that point. They did move it to the nurses after the report came out, because they understood the importance of cleanliness, which the doctors at that point didn't. And I'm talking 2001. But they said, what is the point of prevention if another person will move into that bed and will be fully occupied? Won't save any money. And I've heard that for so many areas where they say it won't save money prevention because somebody else will just step into that gap that's been created. It is very short-sighted. The UK is not alone. The average spend on prevention of healthcare is between 3 and 5%. The UK has now hit about 8%, as it started to actually do more in this space. But all we can do is keep pushing it, and also the tools now. I think that we're not far off that people being able to use their own data to say,
Yeah.
you should have got this, and make it very expensive for people not to invest in prevention.
I think that would help.
That hand up at the back.
Yeah.
I said something that made her hand go straight up. I'm thinking, what did I
We'll go to
say?
this and okay.
No, I mean on healthcare in general, on prevention, it probably doesn't. It's private and out of pocket.
I'm conscious that talked about the gender divide earlier. There's a lot of innovation in the area, which I think is wrong in principle, very much so, but it ends up being things that women pay for. Women are paying for their own health improvements in a way that men are not.
Could you just repeat the question quickly?
So the question was about the gender divide and the fact that ultimately it ends up women paying for the intervention and men not having to or don't do. And there is a piece of research that one of my colleagues has done exactly on that, asking how much women pay out of pocket and how much men pay out of pocket. There was a little bit, some of it is, would men pay for menopause? Because one of the questions was menopause. Of course they're not paying for menopause. Some of them were paying for their wives to have private access for menopause treatments. So there is a lot that's wrong, but the more we can make a noise about it, the more we have interventions like which are digital, which you can get people to invest in, the more we can change it. And I'd say, yeah, we're not in the best way, but we are on the way.
Thank you.
And that's a great example of something.
We have a question, I think, on the Zoom, which I'll go to just straight away because Audrey's alerted me to it.
Yes, I'll read it out. Hi, I'm Catherine from the allergy team. Thank you for a great discussion. I'm interested in the panel's view on the issue of patient trust in tech. People are often skeptical, so how can we ensure that they are with us on this journey? So trust in tech.
Trust. So
I'm going to let somebody else answer.
Adeola, why don't we start with you, since you see patients on a daily basis?
Yeah, I suppose it depends what tech. If we're talking about tech that they, for want of a better word, consume at home, what you can get from your mobile phone or download, as opposed to tech that they encounter when they come and see a professional. Because everybody wants the robot. They're like, I don't want. I have people who've travelled from other parts of the country because they want the robot. So I think that appeals, and I think and even if they don't understand anything about it, it just sounds really futuristic. But I guess it depends on what the product is and how it's presented. And also people's experience of it, because there are lots of apps you can buy that are not entirely accurate, that are not entirely helpful. And I think if you have a bad experience, then that destroys trust.
Yeah, I would take it.
Ekanjali, you had some things to say on this one, if I remember. Yes.
I think we have to take a second to acknowledge actually the future landscape is still a bit unclear. So what if your health span and you taking a preventative approach to your healthcare and logging every symptom you've had anywhere actually becomes linked to financial products, and you get incentivized to remain healthy or penalized if you're not healthy, right? How would you feel about your health data then? So I think sometimes that lack of trust is actually well placed, and it puts us in the healthcare industry with the responsibility we have to our users is, and I'm so proud that us in the UK and in the EU, we have GDPR and data privacy rules that don't exist in other markets, because fundamentally in healthcare, we are protecting our patients. And we have to recognize that the future landscape is still a little unclear. So we'd rather responsibly innovate than just innovate at all costs. And that's certainly my view on that.
Do you think, though, that the use of such a lot of patient-centric data potentially generated by the patient themselves from a lot of different sources can actually lead to us having what I would call the worried well. People who turn up thinking they've got cancer when actually they've just got a spot on their nose, something of that sort.
Yeah, well, I'm sure you've
Is that a
seen it.
problem? Is that going to become a worse problem?
I mean, I think potentially, and I think if your tendency is to be hypochondriac, then you will see, because every symptom could be something. Yeah, and I think it's, and I think there is the danger of unmodulated data if it's just out there. And I think that, you know, responsible products, like where it's contextualized, are much more useful than, you know, just something that you download. And you do have patients who say, but surely it must be this because I've looked at it on Google and
Exactly.
it is this. And so, yeah.
And there's one thing you said, which is you got class 1 medical device. So there is there are the regulators to try and police this environment, which is a bit of a wild west, particularly if you look at consumer health products which are advertised on the internet, claiming all sorts of things. You only have to look at weight loss, and there's a massive amount out there claiming everything, and without a lot of scientific evidence. They present it as if there's some scientific evidence, but have they got a regulatory approval for that intervention? Because after all, it's going to be changing your health by taking that product. So looking at whether or not something has been given regulatory approval. And I say to a lot of medtech companies who they try and go down the consumer health route first because they can get it into the market more quickly. Actually, it's a short-term gain. You're better off getting that evidence base to get the proper regulation, because you're never going to get it adopted by the NHS unless it has been.
Yeah, no, that's interesting. I think we've probably got time for one more question if there is. Fantastic.
I'm curious, how much does it cost for everybody? That you're using?
So how much does it cost for a robot? Because Yasmin wants to buy one. So.
No, I'm just curious.
So the capital outlay for the console is the cheapest is probably about 1 million, and then it goes up to about 5 million. Yes, but and the consumables are also expensive, but that has to be factored against the benefit. I mean, I think the most expensive or the most pressing commodity in the NHS is beds.
Right.
The UK has the highest percentage bed occupancy rate compared with other developed countries, which means we're often at capacity and we cannot admit more patients. And if you could reliably get people home the same day, you would increase the number of throughput, and the robot will eventually pay for itself.
Yes, I think that's.
And there are innovations in the robots themselves. So they're developing smaller, more mobile, that they can be used between, because they're fixed in an operating theatre, aren't they?
Yes,
so that operating theatre, but these robots can be moved. Now they might not be able to do quite the complicated surgeries that you're doing, but they can do some of those surgeries by being able to be more agile, more nimble, lighter, because you also weigh a lot. So there is innovation happening there.
Do you think we'll ever get to the point where you're not required, so the robot will just do it?
I don't think so.
Well, I'm really pleased to hear
I think,
that.
and again, I think it was Ekanjali made the point. Technology aids healthcare, but humans care, and I think that you have to have a human being at the interface. I just don't think you can run a system that is entirely. I mean, you know,
That's
AI
fantastic.
is something that I think we're still needed.
And I think we should end on that note. It was part of one of my questions, but I think we'll end on that note. So firstly, I'd like to thank our panelists. So I think have given us the most fantastic